So my presentation today is entitled Stitching Time, and it's a case study of a medical organisation that we've been working with over the last 18 months, where clearly a work from home strategy is not an option because of what they do. A bit about me then. My name is Phil. I'm a business continuity resilience principal at Terra Firma. I've been working with Terra Firma for about 4 years now. I have 30 years of experience in business continuity going back to the 90s. Some of my previous roles, I've been head of business continuity at ANZ Bank. I'm a fellow of the Business Continuity Institute, and I used to be a member of the board of the Institute as well. If you want to read more about me, then I've got a LinkedIn profile if you're really that interested, but it's not about me, it's about the presentation. So the organisation that we work with is quite an interesting organisation. It's a not-for-profit provider of reproductive health services. They're funded by the community and partners and donors. They an organisation that provide very small cost services, and in some cases free services, to the local community. They operate in 5 of the 6 states in Australia, and they have 16 clinics spread across those states, and a central office for support services, which provides such things as the appointments booking centre. They have an aftercare advice line. They provide corporate services and an IT support environment. But it's the clinics where the interesting aspects of this piece of work actually reside. So they've been operating in Australia for about 20 years. Their clinics traditionally work on a 9 to 5 basis. Other than that, they're pretty normal in terms of an operation. So their central head office is pretty much like any other organisation. So we were engaged by them to address some of the challenges they were having in this space. And the key reason for them approaching us was because they have an operating licence which was due for renewal, actually in January. They have to renew their licence every 5 years. They were coming on the back of having a very seriously negative audit report with quite a lot of items to resolve. Some of the key things that we were asked to address were their site emergency management plans. They were very inconsistent and needing significant review. And we'll come on to why that's the case later. They had no real business continuity plans. They had certain procedures in place to deal with specific issues, but no generic business continuity plan. And no formal crisis management structure or capability. In actual fact, they didn't ask us to look at crisis management, but it became quite obvious to us when we were actually progressing that they didn't have that capability in place. So we decided to include that into our project work. They had quite a few major disruptions that they dealt with previously, so that because they're spread all over Australia, they had experience of floods in Perth. They had impacts from the fires in Queensland. And so they had a lot of experience of dealing with issues, but hadn't done it in a very consistent way. They'd really just muddled together to get things operational again, but failed dismally really in a very cohesive response. So what did we do? So we decided that we'd approach this project by looking at one clinic first to do a business impact analysis. So we chose the largest clinic because we felt that would have the biggest number of activities. We then took that completed BIA to all the other sites. So we visited each site simply because part of the project was to look at their emergency management procedures, and that's almost impossible to do unless you're on site. So we took the BIA we completed for the single clinic to all the other sites and really tried to establish what the variances were to that initial BIA. The sites, as I say, included review of the emergency management plans, and because of that, we had to get involved with some of the tenants that were in their buildings, because there are a lot of them in shared locations, and also the building managers where they were big corporate offices. We then conducted a separate business impact analysis for the central support office And from that, we produce the strategies to recover and the business continuity plans for each site. And at that stage, a crisis management plan, as I say, it wasn't in scope, but we quite quickly realized that they didn't have anything in place. So we agreed that we would develop one and then exercise that plan as part of the project. So the initial BAA identified what the key activities were, and just to explain to you what they do is that there's a list of activities at the top there, which is pretty much all of their services. So they provide contraception services and STI checks. They do vasectomies. They do medical terminations, which is a termination of a pregnancy using medication. And they do surgical terminations, and there are two types. So there's a general surgical termination, which is usually in the first trimester. Then they have a high gestation medical termination, which is anything from terminations at 20 to 22 weeks, depending upon which state you're in. They then provide aftercare services for anybody that's had surgical treatment and medical follow-ups where there's any complications as a result of the surgery that's taken place. Because of all the blood testing they do and the STI checks, they have a pathology collection service as well. So those are the things they actually do for the community, but actually they're not the most critical activities they have. And the ones at the bottom of the list are the ones that they regard as the most critical. So the way they work is they have lists of procedures that are going to be undertaken on a certain day. So list management is extremely critical to them, because without a list, they don't know what they're doing that day, and they can't access the medical records either. So list management and medical records are fundamentally the most important activity they perform. They then have other things they have to do. So waste management and cleaning is clearly critical to them. And consumables and medication management is also critical. They can't do anything without consumables or medication on site, and that includes things like the availability of oxygen, as an example. And equipment maintenance has to be maintained, and that again is happening on a daily basis. So the four activities at the bottom are actually their most critical activities, and all of those have a recovery time objective of less than 1 day. List management is the lowest recovery time objective of, I think, 12 hours. But the actual services themselves are actually less critical. In fact, gentlemen will be very pleased to hear that vasectomies they regard as being the lowest criticality of anything they do. They feel that people can wait 4 weeks for a vasectomy, but the highest criticality of services they offer is the high gestation medical termination, which has a defined end date to it, because they have to complete the surgical termination before the 22nd week, otherwise they're in breach of law. So those are the activities that we came up with as part of that initial BIA. We then took that BIA out to the other sites to try and establish what changes there were from that original BIA. And the first realization to us was the sites are actually not as similar as we first thought. So a lot of what happens on site is left to local management, and that has some implications for the way they operate. We found that different procedures and services were being offered at each location, primarily because in some states they had more than one clinic, and they split the workload across the clinic so that one clinic in isolation didn't provide all the services. But at the other extreme, in places like Perth, where they actually only have one clinic, that clinic provides everything. So the BIA had to be modified significantly for every site to reflect what was actually going on in that site. Also, the take-up of different services was different in different states, mainly because of the population demographics. I have a lot of respect for this organisation because they're there to serve the community. They try to do it in a very cost-effective way, and as I've already said, some of the services are provided free to certain classes of population. And the result is that the different population demographics resulted in different take-up of the services. So some were in greater demand than others, depending on where you were located. Also, every state has different regulations required to to deal with terminations, and they had to comply with those different regulations and capture different pieces of information based on whichever state they were in. As a result of that, some of the operations had their own IT systems in place to deal with state requirements, which were not centrally supported. That created some issues for us because they've been implemented by the local management. They weren't supported by the head office. And in fact, in some cases, the head office had no idea that these applications were in use on site, but they were required by the relevant state authorities. The resource requirements differed across each clinic simply because of the different services they were providing. So if you're not doing surgical terminations, you don't require certain types of oxygen or certain types of medication, but equally in other sites, they required everything. So again, a very different feel for each of the sites we visited. The physical sites themselves were very, very different, and that was a big impact on the emergency management process we were looking at. Some of the sites, quite frankly, were in a very poor state of repair. Others were quite modern in new buildings. And there were some specific issues that we came across just by reviewing the physical sites that we had to deal with. So the emergency management piece of work was the first cab off the rank, if you like, in terms of our visit to the sites. And as I've already said, the emergency management plans were very varied in quality. Because the management of the sites was pretty much left down to the people on site, some of the emergency management plans have been developed in-house. We found one of the clinics had actually gone out to a third-party provider to develop their emergency management plans. The plan was actually quite thick and very robust, but it wasn't necessarily what was needed to support the clinic. Some of the emergency management plans relied on building management, so they relied on what had been put in place by the shared building. And there was limited building-wide integration in some of the sites. And I'll explain that in a bit more detail shortly. In almost every case, we found the emergency evacuation assembly points were poorly located. They were either too close to the building, or they were in a location where you couldn't have, frankly, got people out there quickly. Some of the buildings, I say, were quite old, and the evacuation points were really not in a good location. There was no protection for patients. So I really had to revisit some of the assembly points that they'd allocated. On one of the sites, the other tenant had chosen the same evacuation assembly point as the clinic. This was simply because there'd been no communication in the building between the people that were in the building itself. So that particular building had two tenants, the clinic and another tenant, and neither of them had spoken to each other about evacuation. They'd all gone off and developed their own plans, and there was conflicts between them which were very difficult to resolve. We had another situation where there were, again, two tenants in the same building, and the other tenant was completely unaware that the clinic was holding explosive gases on site, and actually selected their assembly points to be right next to the bottle store. So I established a meeting of minds between the two entities, and they came up with a consolidated emergency management plan, which resolved all the issues that we'd encountered. We found one site that was really interesting because the emergency evacuation door was just too narrow to take a stretcher or a wheelchair. And most of the patients are in stretchers or wheelchairs. So it was going to be difficult to actually get people out if the main entrance was blocked off in any way, shape or form. So again, something that had to be resolved with the owner of the building. So we approached them about widening the doorway and changing the way the door mechanism operated. So those were just some of the things we came up with. Generally, every site had an emergency management plan, but everyone was different. So the outcome for us was to develop a consistent approach to emergency management, which we shared with them. In some cases, the plans were actually really good. In other cases, they were really bad and had to be enhanced significantly. Okay. So what were the challenges in the business continuity management space? So we found that there was heavy reliance on external suppliers of theatre disposables. Things like swabs and gowns and masks were only kept on site in very limited numbers. In the worst case, they only had 3 days of stock available. So they were heavily reliant on deliveries being made on time. There was also heavy reliance on the central support office for the call centre for bookings. And if that call centre operation failed, then really the clinic had no way to continue operating. Although some of the bookings were made directly with the clinic, most of them went through the head office, support office in Melbourne. As already said, most of the ITO solutions were centralised, but some local systems were implemented without any support from a central office. There was really no knowledge about those systems in some cases, and they were reliant completely on the people in the clinics to manage that relationship with the supplier, which is quite interesting because fundamentally the people in the clinic are clinicians. There were really no support people there. They're all nurses and one central manager of the facility. The key thing and the most difficult issue to resolve was that most of the critical services required access to an operating theatre. It's not something you can come across particularly easy, and I'll talk about some of the issues we had trying to resolve that problem later in the presentation. We talked about whether it was possible to relocate some patients in the event of a disruption, maybe move them to a different clinic, maybe move them interstate. But there were some potential legal implications with doing that. So if you move someone interstate and they're in a state where late term terminations can only happen up to 20 weeks, and you move them to another state where it's a lower number, then clearly there'd be a problem actually performing that surgery. So there was a decision made that we would never move anyone interstate, plus the overhead of actually doing that was significant for the organisation. So that wasn't an option that we looked at. We thought about it, but then discounted it. So the other issue that we came across was that most surgical procedures are outsourced to a panel of local doctors. So the way the operation works is the list is produced, and the list will say what's going to happen today. And typically they would have similar procedures on the same day. So vasectomies would all happen on a Tuesday, for example. And then the list would go out to a panel of doctors to say, can you support this list on a Tuesday? This particular operation had no doctors of their own. It was all outsourced. So they relied entirely upon being able to get people on board and available to support their lists on the day they required. That in itself was a bit of an issue because it meant they couldn't move procedures about without conferring with the doctors or surgeons to find out whether they were going to be available on the day that they moved the list to. So lists were pretty much fundamental to making sure that things happened on the right day in the right time frame. Okay, so what did we try to do to resolve the issue? So we talked about reciprocal arrangements to access operating theatres, which we progressed in some cases, but there's some significant issues still remaining. So in some of the states, this particular operation had more than one clinic, and they were in easy reach of each other. So there was a no-brainer decision made to make those clinics available for a reciprocal basis if they were required to support one of the clinics. So that happened easily within New South Wales. They had 3 sites which were quite close to each other. They each had or 2 of them had an operating theatre, so they could act as reciprocal operations for each other. The big problem we had was in the states where there was only one clinic available. Perth, for example, only had 1 clinic. There's 2 clinics in Queensland, but they're 1,000 kilometres apart. So moving people and getting them to go to a different clinic 1,000 kilometres away was perceived to be impossible and unrealistic. So we went out to external bodies to try and find out whether there was anybody out there that had operating theatres that they would be prepared to share on a reciprocal basis with this operation. And the responses we got were quite astounding, really, because I would have thought that people in the health community would all want to help each other, but it turned out that wasn't the case. We spoke to a number of clinics quite close to the operation in Perth, for example. They were very reluctant to share their facilities, even though they had quite a lot of spare time when they weren't using those facilities. So we went to them saying that we'd be prepared to use their facilities at night time or evening on a reciprocal basis, and we would provide the same service to them in return. But really there was a huge reluctance to do that. And we were only able to get one clinic that was able to agree to a reciprocal arrangement. There was also some implications as a result of the costs. So we went to one particular private clinic that said, yes, we'd be very happy to share our operating theatre facilities with you during the evening because they're not in use, but you will need to pay our full private fees to use those facilities. So that's probably an insurable event. So that was investigated as something that could be insured against. It transpired that insurance wouldn't be available without a huge cost. Equally, because this particular organisation works on the basis of low cost or free services, it wasn't possible for them to absorb that cost themselves. So in some cases, it became impractical to go with these private hospitals to use their facilities. I'd say there was a significant reluctance of some of the other providers. In one particular case, there'd been an incident previously where this client of ours had gone to a third party and asked to use their facility. That permission had been granted, but apparently the impact on that organisation was significant because they used the facility for quite an extensive period of time. And because of that, when we went back to them again and asked whether they'd make this a formal arrangement, they said, no, we're not prepared to do that. It's too big an impact on us. We're really not interested in supporting you in this area. The other issues that we had as a result of talking to other third parties was that they were quite keen to ensure that we provided all the surgical cleaning and the equipment. So some of the surgeons we spoke to that had operating theatre facilities didn't have all the equipment that would be required by this entity, and therefore there'd be a requirement to purchase additional equipment at the time of disaster. So that's actually been put into the plan and something that will happen if they ever need to relocate. Another big issue was around doctor and staff availability. So it's very, very easy to relocate your list to another location, but if you can't get your doctors to support that list or your staff are not available to work, then clearly you cannot perform the surgical procedures. So we had spent a lot of time talking to the doctor list in certain areas, asking whether they would be able to support that change in timing. In most cases, the doctors were quite accommodating. Equally, the staff were also very accommodating to work outside normal office hours. This particular operation is typically a 9 to 5 operation, but the way they would operate in disaster recovery mode would be to operate outside of normal operating hours. So probably in the evening, providing their services from 5 to midnight was the proposal. In some cases, it was decided that because there was no alternate facilities available, the only option might be to call 000 if you're partway through a surgical procedure and the lights go out. It's very difficult to do anything other than to call emergency services and get them to respond to that incident and come and support you. We managed to identify alternate suppliers for medical disposables, and these were identified and documented in the BCPs. There was heavy reliance on some specific third parties, which we had to try and break. We achieved that by talking directly to those third parties, understanding what their business continuity arrangements were themselves, but equally identifying other organisations that could provide support. The other thing we did for the consumables was to work out whether we could actually share disposable equipment between the clinics. So there were some arrangements put in place, particularly in local geographies, to have access to disposables at the other clinics. And we also established some flexibility in moving dates for short-term disruptions. So we were working on the worst case scenario. So we were working initially on the premise that if we lost the whole of the surgery, the whole of the clinic, what would we do? But we then drilled down a bit further into what would happen if we couldn't provide some services. Could we move lists for a short-term disruption? And by talking to the doctors, we agreed it was possible to move some lists. Clearly, some of them can't be moved. As I already mentioned, the late terminations are not possible to move because they have defined deadlines that have to be achieved. And the other thing that's going on right now is we're still having discussions with IT. They obviously need to look at some of the systems that are out there being used by the different clinics and bringing them under the control of the central IT department and understand how they are being used. That discussion is still ongoing. Some of the systems that have been put in place, as I say, were put in by the local management and are really unsupported by IT centrally and supported by a local service provider. So again, we had to go to those local service providers to make sure that they had a robust disaster recovery plan for that IT solution, some of which were used to maintain medical records for the state, meeting state-based requirements. Okay. So the strategy for the recovery of the Central Support Office was also proposed, which involved some working from home, but also we're now looking at an alternate site for the call centre, which clearly has to continue. During the pandemic, they did put some work from home arrangements in place for the call centre. They were reasonably successful, but not 100%. So they now think that they're looking at an alternate site for that particular capability, having the knowledge that they can always fall back to the work from home arrangements if they need to. As I mentioned before, we were asked to develop a crisis management plan on the realisation they had nothing in place. There was no central coordination of an incident when it occurred. It relied entirely on local management to deal with the incident. So we developed a crisis management plan for the support office and engaged all of the different clinics in an exercise to show how it would operate in real life. The exercise was a physical disruption to the support centre itself, but clearly it had an impact on all of the clinics, and they had to invoke their business continuity plans to resolve those problems. And ultimately, it was a successful event, but we feel we need to do more in that space. They certainly need to look at how they communicate with each other. The communications process are not robust and needs to be matured. And what hadn't been considered is the time zone implications that are in place. So obviously Perth being a 4-hour time difference from Melbourne created a bit of an issue for us with the exercise. But we managed to overcome that. And now they're looking at how they might extend the hours of a support centre and particularly the management team to cover off a crisis incident response, which would have to be handled centrally because they're actually covering a 12-hour time slot rather than just a 9 to 5 time slot. So they're working on how they're going to do that. They're going to have probably people on call and people available to manage a crisis if they need to be available to do that. Okay, so that was a very quick whistle-stop tour. I finished 5 minutes early, apologies for that. So is anyone going to get any questions?
Oh, Phil, I've got a few questions for you, actually.
Good.
So what do you think, or what would you say would be the greatest epiphany or learning that the client had gone through as a result of you leading them through the BC process? Were there any surprises?
Probably the biggest one is the fact how much they relied on local management of the sites, the clinics themselves. And the people that were doing it were not really site managers, they're clinicians. They're predominantly state-registered nurses that were running the sites, quite senior nurses, but really didn't have a lot of skills in things like crisis management and business continuity and risk management entirely. So that was the biggest epiphany. I think they realised that they needed to provide more support to the clinics themselves in that space.
And how big a challenge was it to fold in BC project participation and real life, work, day-to-day work?
That was always going to be a challenge. Fortunately, some of the clinics have no list days, so they don't actually provide any services, and they use that day to maintain the equipment, update their stocks, clean stuff. And I tried to involve them on those days when they weren't busy, but it was difficult to get people to commit. And there were some cases where I had to be flexible in my ability to speak to people.
Okay. We've still got a few minutes before we take a short break and then introduce Juliet.
Yeah.
We have a question that's come through from our audience. I'll just read it out to you. It says, with the emergency management plans, did they create their own company-wide plan, which sat independent of the ones that building management had, or did they have building management change their EMPs?
Okay, that's a really good question, because it was a bit of a mess, quite frankly. They did not have, they had a central template for emergency management, but it had never been rolled out to the clinics. So some of the clinics had used that template and tried to fit it in as best they could. As I've already said, one particular clinic went out to a third party to do their own emergency management plan that was completely different from everybody else's. And there was at least 4 clinics that are in quite big corporate offices that relied entirely upon the corporate office's emergency management plan. And in some cases, those plans hadn't taken into consideration what services were being provided out of the clinic. So some of the requirements, like relocating people to certain locations, hadn't considered that people might be in wheelchairs and stretchers.
Well, okay. And it's funny, like you don't really know this until you start, peeling open and looking around and having conversations.
Yeah, absolutely.
Thanks, Phil. I've got another question. This is going to be a bit of a challenge to answer without breaching confidentiality. What was the level of commitment, action, budget, etc., from senior management towards development or review of plans and exercises? How would you best characterise their level of commitment?
So because it's a not-for-profit, it's quite a slim organisation. So we were dealing, and our sponsor was actually the managing director of the company. His commitment was tremendous. They had one person allocated to me from the risk management space to support the project. So that was really good. And he was quite supportive of the crisis management piece of work that we did as well. So ultimately, I think it was pretty good. I didn't have any complaints in that area. I think the biggest problem was really the fact that this wasn't communicated well, what we were trying to do to the clinics themselves. So that came as a bit of a surprise to them.
Okay. All right. So how are we going for time? I think we can take one more question before we take a small break. And so was there any conflict in the difference between people's thoughts and ideas about what type of business continuity the enterprise needed and what you ultimately created? I know you mentioned at the beginning that it wasn't intuitive in terms of what were the most critical activities, across the organisation.
Well, I think when we went into this, everyone thought that the procedures they perform were the most critical things they do. It was only when we got into the detail of the BIA, they thought, well, actually, the things that are most critical are the management of the list, because without the list, we can't do anything. And that wasn't really something that was front of mind for them, because they're all, they're nurses, they're there to deliver a service to the community. But they hadn't really thought about what supporting processes were and how important they were to them. So that was a bit of an eye-opener for them as well as us, I think.
And apart from the obvious in terms of needing business continuity, to protect the organisation, I would imagine there would also be a strong element of accreditation for an organisation in the health sector.
Yeah, so as I say, one of the key things they had for them was their operating licence, which is a health licence. They're actually one of the only independently licensed providers of this type of service in Australia. So they were quite keen to make sure everything was in place prior to their assessment period, which was last January. I'm pleased to report they actually got their license, so we must have done something right. But yeah, that was their biggest concern. They wouldn't get their license renewed if they didn't meet all the requirements of the regulator in this space.
Okay.
Phil, I have another question for you. If you can hear me okay. Can you tell us how did they go about contacting their patients? What was their plan to contact people on the list if there was a disruption?
So the list was produced centrally. It's from the support centre. So the plan is to actually go back to the support centre and get them to make the calls through the call centre, which is why the call centre itself is quite fundamentally important to the operation. Some of the bookings were made directly with the clinic. So people would walk into the clinic and say, "I'll come here, I want to organise a vasectomy," for example. But that would then go back to the support office and registered centrally, as well as being captured locally at the clinic. So there are quite a few different ways of getting appointments. They also offered education sessions occasionally for people, typically teenage kids, to come in and be taught about health cleanliness and such and stuff like that. And people would just walk in for those services. They were advertised locally, managed locally, and delivered locally. So there was no support for that at all from the central office.
Phil, how did IT roll into this? Is there a great dependency on technology?
Not as much as you might think. I mean, the lists themselves and the management of people's records are all handled by technology. The technology on site is fairly limited. So IT are still actually having discussions with us about how they protect the environment going forward. And so the biggest concern was how some of these other systems have actually come into being that they weren't aware of, that have been implemented at the local management level. But IT are still looking to talk to us about how they protect the environment. Some of the key things that services they offer through technology is obviously the call center software and the ability to capture, record calls, and then the list management stuff and the hospital records.
Okay. All right, Phil, thank you so much for your presentation. I'm sure a lot of people got a lot out of understanding in some ways what the process is and some of the challenges of doing a BC project.